listen to this talk. I'm going to go straight into the talk, and the title, Red-Eyed Matchstick Men, is actually with reference to Lawrence Lowri, the famous artist who did a lot of paintings of matchstick men. And this first slide, as you can see, first slide please, in the picture, is a picture of the cripples. And this is a picture of the industrial situation in Salford many years ago, post First World War, and depicts many First World War injuries. And if you look a lot more closely at the picture, you can see that on the left-hand side and the right-hand side, there on the left, there's a gentleman with an above-knee amputation. And over on the right, there's a gentleman with a bilateral above-knee amputation. Just to the left, the mid-centre, there's a gentleman with his back towards us who has a claw on his left hand. So these were war injuries which were quite common at the time, post First World War. The picture also shows many children playing in the background who have rather prominent foreheads and very, very thin legs, hence the matchstick men. This shows and demonstrates the level of vitamin nutritional deficiency that was rife at the time, and especially that of vitamin D. In our COVID times that we live in, it is known now that if we take a prophylactic dose of vitamin D, that can help us to fight against infection and can also help to prevent possible infection by COVID. So in order to prevent ourselves getting infected, plenty of sunlight with vitamin D will be also very helpful. Now, Lowri was obviously very, very medically orientated, because if you look closer at this painting of his, in the foreground, you can see the gentleman with two crutches. And his left leg, as you can see, is spastic and is straight. So he's got a spastic paraparesis on that side. And his face, on his right side of his face, the opposite side, he's got a facial nerve palsy. So this gentleman has had a stroke. Now looking behind him, there's a lady just to the centre right of the picture behind him with a neck that looks rather fused and short. And this lady has a condition called Klippel Feil, where she has fusion of the vertebrae in her neck. And that is also associated with a facial nerve palsy and also a cleft palate. Now, if we look further back behind that lady, over to the right-hand side, there are two little figures at the back with deformed legs. So just immediately to the right behind her, there's a gentleman with his back towards us whose legs are deformed, turning inwards, and that is called a varus deformity. Now, to the right of that gentleman, the third figure to the right, there's a little boy with legs that are turning outwards, and that is called a valgus deformity. Now, if we look further at this picture, you can see over onto the right-hand side, there's a tall gentleman who has Marfan syndrome. And Marfan syndrome can also be associated with high myopia. Over onto the left-hand side of the picture, towards the back, you'll see a lady who is clothed in a black robe and dark, and that is because she has photosensitive skin. So she's suffering from photophobia and has photosensitive skin due to a condition called porphyria, which is a disorder of liver metabolism. I saw a patient actually come into my eye clinic exactly dressed like this into my Northwich clinic just a few weeks ago. And she had a condition called porphyria cutanea tarda, which can cause skin rashes if her skin is exposed to the sunlight. To the left of her, there's a gentleman who's looking with his head towards the left with a blue sweater on. And if you see, his neck is inclined, and he has a condition called ankylosing spondylitis, which, as I'm sure people know, can also cause uveitis, which I'll be talking about later. So as you can see from this first picture, nearly every figure has a medical diagnosis. And some of these we're going to be talking about later in the talk. At the end of this talk, there will also be some questions, multiple choice questions, which I'll also go through with you. Next slide, please. So the first, we're going to talk about differential diagnosis of the red eye. Next slide, please. Now, Lowri also suffered from bilateral red eyes since he was a child, and these persisted into adulthood. And later on, we'll find out what the cause of his red eye was. But as people are aware, in primary care, and certainly in GP practice, red eye constitutes about 5% of all consultations that are seen. And the differential diagnosis of that involves a subconjunctival hemorrhage, a conjunctivitis, which can be bacterial, viral, chlamydial, or allergic. It can be due to iritis, especially if the patient presents with a painful red eye. And of course, if a patient presents with seeing halos around lights, is hypermetropic, and is complaining of headache and nauseation and vomiting, we have to think of the diagnosis of acute glaucoma. Next slide, please. So conjunctivitis can be bacterial, in which the patient will complain of a red sticky eye with green-yellow discharge. It can be viral, which is often bilateral, with watery eye. And it can be allergic, where they're complaining of an itchy eye and rather some discomfort in the upper eyelid. And that can be sometimes associated with swelling in and around the eye. Or it can be chlamydial. So some of the signs that we look for in a patient with conjunctivitis are depicted in this slide. So obviously the eye can be red, as we can see on the left lower slide. There may be papillae on examination if we look at the lower conjunctiva and we avert the lid and look at the upper conjunctiva. And these papillae are areas of inflammation around a blood vessel. And these are giant papillae, and these can be caused by a vernal keratoconjunctivitis, like an allergic type of conjunctivitis. They can be due to prolonged use of contact lenses. And they could also occur if there's a foreign body that's been lodged underneath the eyelid for a long time. Follicles may also be present, and follicles are areas where there's an accumulation of white cells, but they're not around a blood vessel. And these are a lot smaller, as you can see. And the follicles in the upper part of the middle picture there can occur in allergic conjunctivitis, and they can also occur in viral conjunctivitis and chlamydial conjunctivitis. In the middle lower picture, we can see conjunctival chemosis, which is a ballooning of the conjunctiva, and this can occur in allergic conjunctivitis. Over onto the right-hand side of the picture, we can see a little child at the top with who is a baby, less than 1 month old, with a very sticky red eye. Looks a little swollen with purulent discharge. And this is a condition that we call ophthalmia neonatorum. The ophthalmia neonatorum is severe conjunctivitis that can occur within the first month of life. And it's usually due to an infection that's transmitted from the mother at birth, through the birth canal. The babies who develop this condition may have a secondary systemic condition, such as pneumonia. And quite often, these children need to be jointly managed by ophthalmology and the paediatricians. One of the commonest causes is chlamydia, and also gonococcus can cause this condition. And as you can see in the right lower picture there, it can sometimes cause a very mucopurulent conjunctivitis. And this, in fact, was due to a gonococcal infection. Next slide, please. Now, just looking at treatments of patients for seasonal allergic conjunctivitis, these patients will present with an itchy eye, and they complain of swelling of the upper eyelid. They have a heaviness feeling in the eye, and they may present with conjunctival chemosis. And the standard treatment for that in primary care has been Opticrom. And Opticrom drops are mast cell stabilizers that are effective in about 1 in 3 patients. Traditionally, they were very cheap. They used to cost about £2 each. They now cost £11. And there is a preservative-free version called Catachrom, which costs just over £36 for a bottle. We then have a drop called Opatanol, which is a mast cell stabilizer and is an antihistamine. This is a little bit stronger than the Opticrom, but it does contain preservative. It has benzalkonium chloride within it. There's then a drop called ketotifen, which is an antihistamine, which comes as Zaditan and ketofol. The Zaditan drops contain preservative, and these cost just over £15. The ketofol drops are preservative free, and the plastic tubes in which they're dispensed are biodegradable, and these cost around £13 for a bottle. Next slide, please. Now, one of the commonest presentations for a red eye, which looks quite traumatic and it can be quite scary for a patient, is a subconjunctival hemorrhage. And this is a diffuse, localized area of blood under the conjunctiva. And often these patients are asymptomatic. And this can be due to coughing, sneezing, lifting, straining, may be related to high blood pressure. It can be due to taking aspirin, ibuprofen, or warfarin tablets. And these cause a bleed in the eye. And this is the characteristic appearance of a subconjunctival hemorrhage. And often the patient is quite worried because of the scary look. The first thing we do with these patients is it obviously will resolve in 10 to 14 days without treatment. So we reassure people and we tell them it's nothing too much to be worried about and it will resolve with time. But it's quite a common presentation that will be seen in primary care, often gets referred to secondary care. Next slide, please. Another common condition that presents is the dry eye syndrome. And there are essentially 3 layers of the tear film. There's a mucin layer on the cornea. Then outer to that, there is an aqueous layer, which consists mainly of water. Then the outermost layer is a lipid layer. And the lipid is produced by meibomian glands, which are in the lid margin. Now, dry eye syndrome can occur due to poor quality of tear film or poor quantity. So when there's a poor quality of the tear film, that is due to meibomian gland disease. So that can occur in blepharitis. It may also occur in a condition called acne rosacea, where they get severe dry eye, rosacea keratitis, and they can get redness on the nose and on parts of the face. Poor quality of tear film can also be due to vitamin A deficiency. So if there's a deficient mucin layer, that will also cause a severe dry eye. And this is quite common in the Far East, where in children, vitamin A deficiency can be quite rife amongst pediatric populations and is a common cause of corneal ulceration. And obviously the treatment of that is to treat the cause. So poor quality of tear film is to treat the cause of the low quality. So if it's vitamin A deficiency, vitamin A supplementation will help. If it's blepharitis, we direct the treatment towards the cause of the blepharitis with an antibiotic drop or tablet and appropriate lubrication with drops. If it's acne rosacea, we will give them lubrication and antibiotics as indicated and direct treatment at the acne rosacea with a tetracycline tablet, such as doxycycline. Then we've got the condition where there is a poor quantity of tear film. And that can occur if there's a problem in the lacrimal gland. So if the lacrimal gland isn't producing enough tears and contributing to the aqueous layer of the tear film, that will cause a poor quantity in the tear film, leading to a dry eye. And there's a condition called keratoconjunctivitis sicca, or Sjögren's syndrome, which can be primary when it's not related to any other secondary cause, or secondary as a result of conditions such as rheumatoid arthritis, systemic lupus erythematosus, vagus granulomatosis, polyarteritis nodosa, or sarcoidosis. So Sjögren's syndrome can be primary or secondary. Poor quantity of tear film can also occur in a facial nerve palsy, as we saw in Lowri's pictures earlier. Now, if the facial nerve palsy is due to a Bell's palsy, due to a peripheral nerve problem, they will get a problem with the upper eyelid, which will lead to exposure of the cornea and lead to a dry. The primary treatment of these conditions is with lubricant drops. And these can be, there are many of these on the market, such as Hyloforte, Hycozam, Thiolose Duo, Clinintest Gel, the Carbamagels, etc. Hyloforte there's Hyloforte, Hylocare, and Hylotears. So that is in decreasing order strength. And these are usually preservative-free drops. And you can use them in patients that are wearing contact lenses. In optometric stores, they're available as the same type of drop, but they're called Hycozam. So we first try lubricants. We may use preservative lubricants to begin with. If those don't work, we can use preservative-free lubrication. If that doesn't work for Sjögren's syndrome, in particular, if the Sjögren's syndrome is severe and the patient has a severe dry mouth in addition to their symptoms, it might be worth using an eye drop such as cyclosporin, such as Icurvis, which can be useful in those situations. Next slide, please. Now, I'd like to talk about a product called Optase, which is hypochlorous acid. So hypochlorous acid is produced naturally by white blood cells and is the first line of defense against harmful germs, such as bacteria, fungi, and viruses, including the COVID virus. So what hypochlorous acid is, it's actual chemical formula. It's the mixture of water, chlorine, and vinegar almost. So it's like a natural, nature's natural disinfectant. And it's actually present in all of us. It's a powerful molecule that is effective against invading bacteria, fungi and viruses, but it's pH balanced, meaning it's gentle on most sensitive skin. And it's now available as a product. It's available for use for the eye as a spray, so it can actually be sprayed over the eye. It has also been used for food disinfection, for wound care, for surface disinfection, and for lid and lash protection. It has no toxic effect at all on human cells, and it does not cause harm or irritation. So there's potential for use of this product as a surface disinfection agent for all the perspex screens that we're using around slit lamps, and for wiping down surfaces in both primary and secondary care in our fight against the COVID infection. So what, next slide please. So what it will do is that it will significantly reduce the bacterial load by 99% if it's applied to the eye or any surfaces. It will also be active against strains of bacteria that are resistant to antibiotics. A single treatment over the eye is comparable to 3 to 5 days use of sterile eyelid swabs and warm compressors in the treatment of blepharitis. And it will also help to kill the Demodex infection that is responsible for blepharitis. Next slide, please. So it potentially has use for patients with blepharitis causing dry eye, patients with blepharitis who are awaiting surgery, such as cataract surgery or intravitreal injections. It could be used for Demodex infection, for chalazions, for fungal infections, for use for acne rosacea, and for viral conjunctivitis as well, which could be due to herpes simplex virus, influenza, or even the COVID virus. And I have seen COVID virus infections on our wards in hospital. Next slide, please. That's just a summary there of all the conditions that which you've been used for. Next slide. Now, another common cause of a red eye is a corneal abrasion. And the corneal abrasion occurs when the surface epithelium is sloughed off due to trauma. And as we know, it stains with fluorescein. And the eye is usually painful, has a foreign body sensation, it will be watery, and it will be extremely red. And this could occur from injury, mechanical trauma or injury. It can occur from a fingernail that's inadvertently been stuck into the eye, or indeed with difficulty taking out a contact lens. Next slide, please. Here we can see an eye that's presented acutely to the casualty department, which is red and sore, and fluorescein stain shows these lines on the cornea. And this patient had long fingernails and then took out the contact lens, and we can see here the fluorescein staining showing the corneal abrasion on the lower part of the cornea. So we treat these patients with cyclopentolate drop stat, which helps to dilate the pupil and will reduce the ciliary muscle spasm. We give them a chloramphenicol ointment about 4 times a day for at least a week. And we often pad the eye, if necessary, until the next day, just to allow the corneal abrasion to heal. And most of these will heal up completely within a week. Next slide, please. And we have the more serious presentation of the corneal ulcer. So the corneal ulcers are a lot deeper than corneal abrasions, and they also will stain with fluorescein. And the eyes will be very much more painful and photophobic. And these can be due to infections, which can be bacterial, can be adnexal infection, or due to a lid malposition, severe dry eye due to, say, a Bell's palsy, or a contact lens related keratitis. They can be viral due to the herpes simplex virus or herpes zoster virus. They can be due to a fungal infection. In the Far East again, if people are working in paddy fields, they often, the paddy rice plants can actually hit the cornea, causing fungal keratitis. They can be due to a protozoa, and the commonest protozoa that's in contact lens and is ubiquitous in the environment is a Acanthamoeba. So when any contact lens wearer develops a corneal ulcer, we have to potentially suspect an Acanthamoeba keratitis and treat that appropriately. Corneal ulcers can arise from severe mechanical trauma, or they can be due to chemical injuries such as alkali injuries or acid injuries. Alkali injuries are always worse than acid injuries. And that's because the alkali will bind to the lipid within the cornea and get into the cornea, causing severe uveitis and possibly secondary glaucoma and cataract if they're not treated appropriately. So anyone with an acid or alkali injury has to have an immediate washout with plenty of balanced salt solution presenting in our casualties, with plenty of water to get as much of that chemical out of the eye as much as possible. And we then treat these appropriately with steroid drops, antibiotic drops, and vitamin C tablets if needed. Obviously, infective corneal ulcers are emergencies that are all referred through to secondary care, and we will treat these intensively with antibiotic drops, and we will scrape them to try and find the source and the cause of the infection. In contact lens wearers, we will keep the contact lens case and the contact lens and send those for culture as well, as that can also help with our diagnosis and subsequent treatment. Next slide, please. So just to show you some examples of corneal ulcers, the top left slide was a contact lens wearer who developed a painful red eye. We can see there's an area of fluorescein stain. And this is a very small corneal ulcer that is a contact lens related keratitis. And this was successfully treated with ofloxacin drops hourly and resolved within a few days. We did send the contact lens also for culture as well as the contact lens case, and it just grew a streptococcus organism. The left lower slide is a herpes simplex keratitis. And as we can see there, it looks like a Chinese letter or branches of a tree branching out into the center of the cornea. And this is due to herpes simplex viral infection. And this is effectively treated with acyclovir ointment or Virgan we use these days. And that will effectively treat the infection. We'll see in this condition, steroid drops are completely contraindicated, but it's diagnosed by putting a fluorescein stain in the eye and shining a blue light onto the cornea that helps us with the diagnosis. The top right slide, as we can see there, and we can see a large corneal infiltrate in the center of the cornea. And this was a patient who presented initially with a conjunctivitis. and had a Hickman line in for treatment of breast cancer. The Hickman line then subsequently got infected, and an endogenous infection spread from that to the eye, which then infiltrated the cornea, causing a large corneal abscess. This was initially treated with an anterior chamber tap, which grew Pseudomonas infection. And we gave the patient ciprofloxacin tablets, 750 milligrams BD, and plenty of ofloxacin drops every half hour, and admitted the patient to the ward. The cornea then started clearing within a few hours of starting treatment. But within a few days, the cornea melted centrally, causing a corneal perforation. And here we can see that the anterior chamber is very shallow, and there's a central corneal perforation. And we treated this with superglue initially, which glued the cornea, and then she needed a subsequent corneal graft. Thankfully, 10 years later, her vision is 6/9 in that eye. The bottom right cornea, we can see, is a chemical injury, and this is due to an acid burn. So this is a lady who was in prison, and an inmate threw some acid, which was used for cleaning, I think in one of the store cupboards, onto her face, and this caused a severe corneal burn and corneal injury. And that cornea, unfortunately, is scarred now for life, and the vision is poor despite treatment appropriately with steroids, antibiotics, and vitamin C. Next slide, please. That was just an example of some of the worst scenarios there that we see in our practice. But of course, in primary care, if anyone sees potential red eye with a possible corneal ulcer, of course, we will see those in secondary care as emergencies. Another common cause of the red eye is episcleritis, which is like a localized superficial inflammation of the episclera, as we can see there on the slide on the right. Not really too sure what causes it, but there has been associated with rheumatoid arthritis. It can occur in people who are tired, or in dusty, people who are working in dusty environments. So if someone's got a fan blowing on one side of the face, quite often you'll look at them in the office and you'll see that one side of their eye can be red. And most of these patients are asymptomatic with mild irritation or mild pain. And quite often the condition will settle on its own. If the eye, however, becomes uncomfortable and is sore and is red and a little painful, we can give topical treatment with a short course of steroid eye drops, which helps to settle the condition down rapidly. Next slide, please. A much more serious condition is a condition called scleritis. And scleritis causes a really deep throbbing pain within the eye. The eye is severely red. And this is typically associated with rheumatoid arthritis. So about 50% of patients with scleritis will have rheumatoid arthritis. But it can also occur in other conditions, such as ankylosing spondylitis, as we saw in Lowri's picture earlier, systemic lupus erythematosus, vagus granulomatosis, and polyarteritis nodosa. It can occur also in sarcoidosis. It's also important in the history to exclude an infection. So it can occur in herpes zoster infections. It can sometimes occur in severe bacterial infections, such as Pseudomonas. Often the patient is kept awake at night because of the pain. And we usually treat these patients systemically with non-steroidals initially, such as ibuprofen or flurbuprofen. If those don't help, we will give oral steroids. Topical steroids can also be given as adjunctive therapy, but the main form of treatment is systemic with oral tablets. If oral steroids don't work, we can try other immunosuppressives such as cyclophosphamide, which can be given IV. Next slide, please. On this slide, we can see different types of scleritis. So in the upper slides, we can see that the scleritis with deeply red, painful eye, which is non-necrotizing. And typically, that can be associated with rheumatoid arthritis. In the bottom two slides, we can see these cases, you can see the blue areas on the sclera, which is shining through, because the sclera has become so inflamed that it's become very thin. And the left side, the bottom lower slide there, is scleritis, which is necrotizing, which presents with inflammation. So the eye is deeply red, as well as the thin sclera. On the lower right, we can see that the blue sclera is shining through. The eye is not as inflamed because the eye has been chronic inflammation due to the scleritis. We can see that a mature cataract is developed there. So the scleritis here is without inflammation. So you can get scleritis, which is non-necrotizing, as in the upper pictures, and scleritis, which is necrotizing with inflammation and without inflammation. These patients, if there is necrotizing scleritis, we will give them much more immunosuppression with cyclophosphamide, methotrexate, and we may even give them intravenous infliximab treatment. Next slide, please. It's important to also remember in scleritis to exclude an infective cause, because if we treat a patient with immunosuppressive agents and they have an underlying infection, the infection could cause the scleritis to get worse. So we do need to also exclude possible fungal infections from the history. We need to exclude this condition that we can see in the top left slide called herpes zoster due to shingles. You can see on the top right side, this is a nodule that is caused in rheumatoid arthritis and causes a nodular scleritis. The scleritis can be anterior or it can be posterior. So in these patients, we also have to check the fundus and make sure that there's no inflammation around the optic disc, as we can see here in the bottom right view, the swelling of the optic disc that we can see due to posterior scleritis. An ultrasound that we do in secondary care and clinic can also be helpful, as we can see on the bottom left, which shows a thickened sclera. Next slide, please. Another cause of a red eye that you will quite often see in primary care is uveitis, which we treat in secondary care. And uveitis causes a red, painful, photophobic eye. And it can be anterior, where it may be acute, recurrent, or chronic, or it may be posterior, where it causes inflammation in the vitreous, in the retina, causing a retinal vasculitis, or a choroiditis. There are some patients who may present with a severe panuveitis, which affects both the anterior and the posterior part of the globe. Next slide, please. So an anterior uveitis will cause a photophobic red eye with reduced vision. The causes of iritis, I usually call them the eyes of iritis. The commonest is idiopathic. When we're treating a patient in clinic with uveitis, we're like detectives. Arthur Conan Doyle was an ophthalmologist. But what we need to do is to ask the relevant questions to try and find out what the cause of that uveitis is. So most commonly, probably in about 60 to 70%, we may not find a cause. But it can be associated with systemic disease. So there may be an inflammatory joint disease. such as ankylosing spondylitis, psoriatic arthritis, or iritis syndrome. Iritis syndrome is a condition that causes uveitis, arthritis, and urethritis. And it's often due to either chlamydial infection or Campylobacter or Yersinia infection. It may be due, uveitis may be caused by inflammatory bowel diseases such as Crohn's disease or ulcerative colitis. It may be caused by immunological causes, which may be autoimmune, such as sarcoidosis or Behçet's syndrome. Behçet's condition, they get quite often mouth ulcers. There may be an infective cause, such as shingles, toxoplasmosis, TB, syphilis, that we often call Lowritic disease, or HIV. And often we can find and establish the cause by taking a detailed history of the patient's medical problems. We inquire whether they have any pets at home, if they have any cats, could have toxoplasmosis. We ask and inquire if there has been any tick bites, or whether there have been for any walk in the forests. That's going to occur in Lyme's disease. So the history will direct us towards the cause. All uveitis patients, we will also dilate them after examining them at the slit lamp, and we'll look at their retina in detail in case we can establish a cause from their retinal examination. Next slide, please. Now here we can see some signs that we can see on slit lamp examination. So patients with uveitis will quite classically present with a ciliary flush. We can see on the top left slide there. The eye will be painful and photophobic. Due to the inflammation in the anterior chamber of the eye, the iris will become sticky and will stick down to the lens, causing a posterior synechia and an irregular pupil that we can see in the top right slide. On slit lamp examination, we can see cells, accumulations of cells on the back of the cornea that we call chorotic precipitates. And when the optometrist is examining the patient, looking for signs of uveitis, he keeps the slit lamp beam around a sort of 40 degree angle, and the length of the beam, if that's narrowed, and the room should be darkened, and the zoom of the slit lamp should be increased, you should be able to see in patients with uveitis some cells dancing between the beam that is in line with the lens and the beam on the cornea. And these are cells, and these are like dust in a projector beam. There also may be flare present in the anterior chamber, which is seen as smoke, and the smoke is proteinous exudation. So these spots that we can see on the lower part of the cornea are chorotic precipitates that are a hallmark sign of uveitis. Now in the bottom right picture there, this is a patient with very severe uveitis. And in severe uveitis, in fact, this condition occurred due to iritis syndrome. And the patient presented with a bowel infection, a joint problem, severe uveitis and urethritis. And this, the level of inflammation has actually caused pus to occur in the lower part of the anterior chamber, which we call a hypopion. But this is a sterile hypopion. Now, if the patient had had a cataract operation and you'd see a hypopion, they may well have a very severe condition called an endophthalmitis, which obviously needs ASAP referral to us in casualty for us to see, which is an extremely sight-threatening condition. So a post-op patient with a hypopion must be referred urgently, but so too must a patient with severe uveitis with hypopion, so that they can get intensive steroid treatment to treat their eye condition appropriately. Next slide, please. Now, these are some diagnoses from the fundus examination that you can sometimes pick up in patients with uveitis. Now, the top left fundus, we can see here that the arteries are occluded. So there is a retinal arteritis, and a retinal arteritis can occur in autoimmune conditions such as systemic lupus erythematosus or vagus granulomatosis or polyarteritis nodosa. There is also pigment in the back of the eye in this case, and pigmentation can occur in toxoplasmosis. But with these two together, this patient was actually found to have syphilis and was treated appropriately then with systemic penicillin intravenously and oral steroids. Now, the bottom left picture, you can see a patient that has presented with a mild vitritis and a necrotizing retinitis. There's a white patch in the middle with hemorrhages on its surface. And it looks rather like a pizza pie appearance, we call this. And this is due to cytomegalovirus retinitis. And this patient actually had HIV and was treated appropriately with ganciclovir, intravenously, then orally. And that successfully resolved the retinitis. The top right-hand picture, we can see that there is like a branch angiitis, an inflammation of the arteries, and a paraphlebitis around the veins. There's also a swollen disc, and there's almost a hemorrhagic picture which rather looks like a central vein occlusion. But because the arteries are completely white, it's much more indicative of a severe angiitis. You can get an angiitis in cytomegalovirus infection as well. Often it's called a frosted branch angiitis. But this is affecting all four quadrants, and there's a swollen disc. And this patient was actually found to have a tuberculous vasculitis in the retina. So was treated appropriately with TB treatment. The bottom right picture, we can see here that there is a fogged out appearance of the fundus with areas of retinitis that we can see. And we call this appearance the headlight in the fog appearance. And this is classical of toxoplasmosis retinitis. And this patient was appropriately treated with sulfonamide and azithromycin. Next slide, please. Now, one of the last causes of red eye I'll deal with in this lecture is acute angle closure glaucoma. So these patients are usually hypermetropic. They're usually around 60 years of age. They will have shallow anterior chambers, and they will present with a painful headache, nausea and vomiting, redness, photophobia, reduced vision, and halos around lights. The eye may be hard, and the pressure will maybe way above 40, maybe even 60. The pupil will be fixed and semi-dilated. So these patients need urgent referral to secondary care. And the treatment for us would be to give them intravenous acetazolamide to lower the intraocular pressure and get the eye more comfortable and get rid of the corneal edema. We also give them pilocarpine drops to both eyes to deepen the anterior chamber. And once the corneal edema has resolved after a day or two of treatment with oral acetazolamide, we will give them laser iridotomy treatment to both eyes. And we treat the other eye to make sure that that doesn't progress to an acute angle closure attack in the future. Next slide, please. So that represents all the causes of red eye that we'll deal with in this lecture. Now I'll let everyone listening in to do some of the work. So we've got just a little bit of a multiple choice question quiz here. So I'll show you about 5 slides, and I'll ask you for a diagnosis of which you have 3 choices. So it's rather like the chaser quiz, but you're don't have to beat the chaser here at all. It's rather more the feedback and reflection for yourselves. So this is a first eye that I'll show you here. And as we can see, patients presented acutely with a red eye. And we can see some signs on this photograph. And next slide, please. So the quiz will be, is this blepharitis, dry eye, or conjunctivitis? So we have to, if you have the last slide again, please. As we can see, hopefully everyone's had a chance to answer that. As we can see, the eye is sticky. And some correct answers coming in to me now. There's yellow discharge. So this is an eye with conjunctivitis and will need treatment with antibiotics such as chloramphenicol ointment, and that will resolve. Next slide. So the answer is C. Next slide, please. So this is a baby who is less than 4 weeks old, who presents with a red puffy eye, and you avert the eyelid and we can see the lashes and what's underneath the eyelid there. So next slide, please. So the question here is this a blocked tear duct, ophthalmia neonatorum, or allergic conjunctivitis? If we have the last slide again, all correct answers coming here. So within the first 4 weeks of life, we can see there's a sticky eye, sticky lashes, there's a little bit of mucopurulent discharge there seen underneath the eyelid. So this patient has ophthalmia neonatorum, commonest cause of which is chlamydial conjunctivitis. Next slide. So the correct answer is B. Next slide, please. So this patient presents with a red eye and you put some fluorescein in and you see this appearance on the cornea. Next slide, please. So is this marginal keratitis, a geographic corneal ulcer due to herpes simplex keratitis, or a corneal abrasion? Brilliant. Okay, so if you have the last slide again there. So what we're seeing here on this slide, and this is a little bit of a tricky one, is that we can see the fluorescein stain in the center. So you see that fluorescein stain is like parabolic shaped. So it's a definite corneal ulcer going on in the center there. The fact that it stains means that it's not a marginal keratitis, okay? There's also a little branch coming out of one side, as we can see. So it's branched, so it's dendritic, so it's a branch-like ulcer. So this is actually a herpes simplex keratitis ulcer. And when they become a little bit confluent like this, we call them geographic ulcers. So this is an ulcer due to herpes simplex keratitis. It's not a corneal abrasion, but I noticed that some people did put C. Sometimes in some scenarios, it can be difficult to distinguish between a corneal abrasion and a herpes simplex keratitis. But we always err on the side of herpes simplex keratitis if we see a branch coming from the ulcer, because that needs treatment with acyclovir ointment to help. So the correct answer, next slide please, is B, geographic corneal ulcer due to herpes simplex keratitis. Okay. Next slide, please. So this patient presents with reduced vision. And you see this appearance of the eye. So I'll give you just a minute to look at that carefully. Next slide, please. This is a little bit of a tricky one. I'm going to ask you, is it endophthalmitis, sterile uveitis, or hythema? Yeah. Okay, the last slide again. So this is a tricky one, I said. Some people have got it right. Some people haven't, partly because in my talk I showed you a slide of a patient with Iritis syndrome with a hypopion who had not had a cataract operation. So this patient actually has a lens implant in place. Okay. I should have told you that in the history. I wanted to see how many people could actually see it. So this patient has a lens implant and has a hypopion. And therefore the diagnosis here is actually endophthalmitis, okay? So in an endophthalmitis, they've had a cataract operation. Sterile uveitis, they may not have had a cataract operation, but they may have other systemic symptoms that have caused that uveitis. A hythema is blood present in the anterior chamber, okay? A hypopion is pus in the anterior chamber. So this is a hypopion that we actually saw in that picture, which is inflammatory cells at the bottom of the anterior chamber. So if we just go back to the last slide there, if we look closely at that lens, I don't know, obviously, it depends on how big your screen is, whether you can actually see the reflection of light coming off that lens. There's actually a lens implant in that eye. So the patient has had a cataract operation and therefore has an endophthalmitis, and that comes in very urgently to us to treat. And obviously when you see the patient in reality, you'll be asking a history of whether they've actually had a cataract operation or not. Okay. Next slide. And next slide. Now this was a painting of Lowri when he was young, and you can see here he's got red eyes bilaterally. Okay. Next slide, please. So this is a self-portrait when he was older. So if you look carefully at that picture, of course he's got bilateral red eyes, and I want people to look at his face and consider what the possible diagnosis might be. Next slide, please. So is this blepharitis, acne rosacea, or sarcoidosis? Great, all correct answers coming in there. So we go back to the last slide. As you can see on that slide, he has a red nose, a bilateral red eyes. This was called the head with the red eyes, this painting. And we can see he's got redness on his cheeks and also on his chin. One of his sisters also suffered from acne rosacea, and his mother also suffered from acne rosacea, so it is familial. So he had acne rosacea, which was obviously the inspiration for this painting. And I'm pleased that nearly everybody got that one absolutely correct. So that's the end of the quiz. And that's the end of my lecture. Thank you very much for listening. I hope everybody learned something there from my talk. There may be some questions. If anyone's got any questions, they can put them through on the chat line.